In Chapter 6, we're going to look at drugs used in anesthesia. We will start by reviewing general anesthetics, and specifically we're going to focus on inhaled anesthetics. When you look at this diagram, it reminds us about how anesthetics can compartmentalize in the body. If you inhale the anesthetic, it goes into the blood. Obviously, it's going to make it into the CNS, but many of these very lipid-soluble drugs can sequester in the fat, which can serve as a storage reservoir for a number of lipid-soluble drugs. When I look at the properties of specific inhaled anesthetics, the first thing that I would do is think about the names of the drugs. Nitrous oxide, probably a drug that you all know, maybe a drug that you've even been administered before. Nitrous oxide, sometimes referred to as laughing gas, is a very common inhaled anesthetic. The other inhaled anesthetics, drugs like sevoflurane and desflurane, they end in the letters fluorane, F-L-U-R-A-N-E, indicating one of these fluorinated inhaled anesthetics. But if you focus on the last three letters, A-N-E, well, that's the first three letters of the word anesthesia or anesthetic. So nitrous oxide and the anes are your inhaled anesthetics. When I look at the first column, MAC value. MAC is the minimal alveolar anesthetic concentration at which 50% of patients do not respond to a surgical stimulus. It's kind of a fancy way of saying that a MAC value is like an ED50. It's really a measure of anesthetic potency. And the rule is this: the higher the MAC value, the lower the potency. So when I look at nitrous oxide with its MAC value of 104%, that tells me nitrous is not a very potent drug. Compare that to sevoflurane or desflurane, 2% and 6%, those are much more potent drugs, indicating that it doesn't take very much sevoflurane, for example, to anesthetize the average person. With nitrous oxide, in fact, because its MAC value is greater than 100%, you can never fully anesthetize somebody with nitrous oxide as the sole agent. It's popular to combine this drug with other anesthetics, other inhaled, or perhaps even other IV anesthetics, but you can never use nitrous as the sole anesthetic because you cannot guarantee that the average person will be fully anesthetized. The next column is the blood gas ratio. What this column is going to predict is onset of activity. It'll also predict onset of recovery as well. When we think about the blood gas ratio, the rule is this: the lower the number, the more rapid the onset. So nitrous oxide, compared to, let's say, desflurane, has a more rapid onset of activity. Desflurane is going to be much slower. Basically, it's going to be more soluble in the blood and slower to move into the CNS. If a drug has a rapid onset, you would expect that it will have a rapid recovery as well. That's true for nitrous and sevoflurane compared to desflurane. Remember, the lower the number, the more rapid the onset. When I think about cardiovascular effects for these drugs, it's very minimal. And specific characteristics, I really don't see a good test question here. Certainly when I think about nitrous oxide, that rapid onset and recovery is the most significant property of this particular drug. In various anesthesia protocols, we can certainly use combinations of drugs. That can be combinations of inhaled anesthetics like nitrous oxide and another drug, or you can combine your inhaled anesthetic with IV anesthetics or local anesthetics. As we discussed in the table, MAC value is the concentration of inhaled anesthetic as a percent of inspired air at which 50% of patients do not respond to a surgical stimulus. We indicated that MAC is a measure of anesthetic potency. We know the more lipid-soluble the anesthetic, the lower the MAC value and the greater the potency. MAC values are additive. That's why if we use combinations of drugs, we can have a very effective anesthetic effect in these patients. MAC values are lower in the elderly and in the presence of CNS depressants like opiates or sedative hypnotics. In the table, we've already considered rate of onset and recovery because these depend on blood gas ratios. The more soluble the anesthetic in the blood, the slower the anesthesia. So anesthetics with a high blood gas ratio have a slow onset. Anesthetics with a high blood gas ratio also have a slow recovery. Whereas anesthetics with low blood gas ratios, they're going to have a rapid onset, and you also get rapid recovery. The next group of drugs we're going to look at are IV anesthetics, and we'll start with the benzodiazepine midazolam. Remember that midazolam is a short-acting benzodiazepine. It's great for preoperative sedation, and as a benzodiazepine, it has the property of anterograde amnesia. In fact, many of our benzos have this property, but probably the most classic for this clinically is midazolam. But this same property has been abused. When you have anterograde amnesia, you don't have any memory for a period of time after administration. The drug flunitrazepam, known by its trade name Rohypnol, has been abused as a date rape drug, taking advantage, if you will, of this property that you don't remember anything after its administration. Well, clinically, when you use midazolam, the same thing can happen. Imagine that it's a great day for you because you're going in for your colonoscopy. You know what? That's the day that you want midazolam. It'd be great if you didn't remember exactly what happened on that day. And so that's a drug that's very commonly used prior to a colonoscopy. An advantage of using benzodiazepines like midazolam as IV anesthetics is that we can use the drug flumazenil to help the patient recover from anesthesia. We can certainly use flumazenil because of its ability to block BZ1 and BZ2 receptors and overcome the actions of midazolam. Propofol is a very, very popular IV anesthetic. I don't know about you, but I don't think you can say the drug propofol anymore without automatically thinking about, that's right, Michael Jackson. So you automatically think about, because Michael Jackson was using this drug, well, he was using it to help him sleep. He was combining this drug with a lot of benzodiazepines at the time of his death. But for our purposes, propofol is a very effective drug for induction and maintenance of anesthesia. The way that this drug works seems to be through GABA. It has GABA effects, inhibitory CNS depressant effects that can lead to anesthesia. Propofol also has antiemetic effects. I call that a bonus. Isn't it nice when the anesthetic that you're taking also can prevent you from experiencing nausea and vomiting? This could become very, very important if you're undergoing a surgery that can cause emesis. Surgery on the eyes, for example, is very emetogenic. Propofol would be an ideal agent in a situation like that. It is a CNS and a cardiac depressant, perhaps because of its GABA effects. If we compared propofol to another anesthetic called etomidate, this drug has much less effect on the heart, with fewer cardiovascular effects. This drug is very effective in patients who have pre-existing cardiac disease. The next IV anesthetic is fentanyl. This drug is an opiate used for induction and maintenance of anesthesia. Maybe one of the more outstanding properties of this drug is that it's 80 times more potent than morphine. It actually makes this drug a candidate for abuse among physicians. Be careful, don't do that, by the way. But fentanyl is great as an anesthetic. It does depress respiratory function, so we have the antidote naloxone to recover if necessary. Our final IV anesthetic is ketamine. It's a drug that's known as a dissociative anesthetic, which means you don't detect any sensory input. Basically, ketamine makes you catatonic. It works by blocking NMDA receptors. Remember that this is a receptor for glutamate. Ketamine and the drug PCP work very similar as NMDA receptor blockers. Ketamine can be used for the induction of anesthesia, but it does have some very interesting properties. And this drug has been abused because it causes this emergent delirium and hallucinations. So while you're catatonic, boy, you're having some good dreams. It does have some cardiovascular stimulatory effects, but this drug has very little effect on respiration, making it a popular choice in asthmatics, although it can increase intracranial pressure. Our third group of anesthetics are the local anesthetics. When I look at this diagram, it allows me to discuss the mechanism of action of these drugs. In fact, let's remind you of a couple of points about local anesthetics. All locals are weak bases, and they have pKa values of approximately 8. Now, we have to go all the way back to ionization principles that we covered on page 4 to remember exactly how these drugs are going to work. Since they're weak bases, they're going to exist in two forms, ionized and non-ionized, and that's shown on this diagram. They can either be RNH3+, remember, we had previously called that BH+, B for base, or RNH2, which we had previously called B, which would be the non-ionized form of the drug. Think about this. If those are the two forms of the local anesthetic, which of those forms is the active form? It turns out that it's the ionized form. It's the ionized form of the local anesthetic that binds to the inside of the sodium channel, inhibiting its activity. When I look at the state of the sodium channel as it's shown here, you should recognize this as the inactivated state. The M gate is open and the H gate is closed. As we saw back in our chapter on antiarrhythmic drugs, this is the inactive state of the sodium channel. So that's how local anesthetics are working. They're going to prolong the inactivated state, preventing the sodium channel from returning back to rest. But here's some bad news for you. When you give somebody a local anesthetic, I want you to think about whether or not this drug is going to exist primarily in its ionized state or its non-ionized state. Consider the drug's pKa. Ask yourself this question. Are most pHs in the body less than 8 or greater than 8? And that's an easy question to answer, right? pHs in the body are all lower than 8 typically. So that means that's a more acidic environment relative to the drug's pKa. What's the predominant form of the local anesthetic? Ionized, the BH plus form. If you're thinking, why is that bad news? The ionized form, after all, is the active form. Do you see from the picture? We have to get that ionized drug inside the cell somehow, but ionized drug doesn't cross membranes. So the ionized drug has to be converted to the non-ionized form to cross the membrane. Even though that's a very small pool of non-ionized drug, when it crosses the membrane, it can then be converted to its active form, binding to the sodium channel, inhibiting neuronal firing. Every time that non-ionized drug moves into this cell, you're going to reestablish a new equilibrium outside of the membrane, where some of the ionized drug becomes non-ionized. So we're always going to have a very small pool of non-ionized drug that can get into the cell and become activated. If you look in the margin, there are several toxins listed over there that are sodium channel toxins. On this diagram also we see tetrodotoxin and saxitoxin. The reason why we show you these toxins work as sodium channel blockers, so their mechanism is very similar to the action of a local anesthetic. When we think about local anesthetics, all local anesthetics can be divided into two categories, either esters or amides. But all of the drugs have a common ending, and that would be cane. So local anesthetics are the canes. But how do I subdivide these drugs into esters and amides? I simply remember the rule that an ester has one I in its name. The part of the drug name, cane, contains an I. If the prefix for the drug's name does not contain an I, then it's an ester. But an amide has more than one I. So we know we're going to get an I from cane. If I get an I in the prefix, like lidocaine, well, that's an amide. Simple way to remember, one-eyed ester. One-eyed ester. Those are going to be your esters. Those drugs are metabolized by plasma and tissue esterases, whereas amides are metabolized by liver amidases. So we know how to classify the drug, and we know the enzymes that are going to metabolize the drug by following that rule on how these drugs are named. How about this as a question? Way back in general principles, we were talking about the first pass effect. We were talking about the fact that when certain drugs are taken orally, they can be extensively metabolized by the liver. Take lidocaine. That was an example that we used back then. If I take lidocaine orally, what happens? It's extensively metabolized by the liver. That very much limits its oral bioavailability. Now you can explain exactly why. It's because lidocaine is an amide, and it's metabolized in the liver by amidases. We want to look at nerve fiber sensitivity. The rule is this: the smaller the nerves and the faster their firing rate, the more sensitive they are to your local anesthetics. This is a very similar concept to what we covered back in antiarrhythmics, and it also relates to the use of anticonvulsants as well. Think about it. When you're dealing with arrhythmias, you want the drugs to target the part of the heart that is firing the fastest. That will depress cardiac firing, hopefully having an antiarrhythmic effect. It's the same thing that you want to happen when you're treating seizures. Where you're having excessive neuronal firing leading to the seizure, that's where you hope drugs like phenytoin or carbamazepine are going to work, by blocking sodium channels. Same thing for your local anesthetics. They're sodium channel blockers. They're going to block the nerves that have the fastest firing rate. So here's the order of sensitivity. Type B and C fibers are going to be affected first. These are fibers that mediate pain transmission. Type A delta are affected next. These are fibers that transmit pain and temperature. Then it's type A beta and type A gamma, followed by type A alpha, which are your motor neurons. So the pain fibers are affected first. Type A beta and type A gamma, by the way, mediate touch and pressure. So those are less affected, and the motor neurons are the last to be affected. Importantly, recovery is in reverse order. Your motor neurons are the first to recover. You then can start to sense touch and pressure before you sense the pain. The pain fibers are going to be the last to recover. When you think about administering a local anesthetic, one of the ways to localize that drug is to co-administer it with an alpha-1 agonist. Perhaps you could add epinephrine to your local anesthetic. The vasoconstrictive effect prevents that drug from going into the systemic circulation. But what's the local anesthetic that does not need any help from an alpha-1 agonist or from epinephrine? Look in the margin for the note about cocaine. Remember, cocaine has its own intrinsic vasoconstrictive properties. This is a drug. Not only does it work as a local anesthetic and block sodium channels, it can also block the reuptake of norepinephrine. With more norepinephrine in the synapse, you get your own vasoconstrictive effects from this drug that, by the way, can lead to nasal ischemia. So think about it. Cocaine has its own intrinsic vasoconstrictive properties. When you think about side effects of local anesthetics, really the allergies from the esters are a very popular question. Esters form PABA and amides do not. So esters are going to cause allergies. If you put our phrase together with what we just learned about side effects, you can come up with the phrase one-eyed ester gets allergies. And you've covered a couple of the important properties of local anesthetics. When you think about skeletal muscle relaxants, focus on exactly where these drugs are going to work to relax the skeletal muscle. The target for these drugs most often is the nicotinic N sub M receptor found at the neuromuscular junction. We see that receptor depicted for us right here. The receptor has 5 subunits. Notice that 2 of those subunits are alpha subunits. That's where acetylcholine is going to bind. In fact, in order to activate this receptor, I need a molecule of acetylcholine to bind to each of those subunits. 2 molecules are required to activate this N sub M receptor. In fact, you can say that most often the skeletal muscle relaxant drug is simply going to block the binding of acetylcholine to one of those alpha subunits, and that's how these drugs are going to work. They're very popular in anesthesia and intubation procedures. We divide skeletal muscle relaxants into 2 categories. The first category is non-depolarizing, competitive nicotinic antagonists. You should focus on each of those words and compare it to our next group of drugs. Simply put, these drugs are blocking those alpha subunits of the N sub M receptor, preventing the binding of acetylcholine. While tubocurarine is considered the prototype of this group, it obviously is not a drug that we use anymore. We will mention several that are used on our next slide. Because these drugs are competitive inhibitors, they can be reversed if I could increase the levels of acetylcholine in the synapse. I can do that with acetylcholinesterase inhibitors like neostigmine or pyridostigmine. The drugs are going to be very selective for skeletal muscle, causing progressive paralysis of the face, limbs, and respiratory muscles. But they have no effect on cardiac or smooth muscle and no effect in the CNS. Remember, they are targeting N sub M receptors found only at skeletal muscle. The way to recognize commonly used non-depolarizing skeletal muscle relaxants is to look for two common endings, curium or curonium. Examples of curiums would be atracurium or mivacurium. Curoniums could be drugs like pancuronium, vecuronium, rocuronium. So if I see either of those two endings, I know that I'm looking at a non-depolarizing neuromuscular blocker. Atracurium is a drug that is considered safe in hepatic or renal impairment. Here's an interesting property of this drug, that it spontaneously inactivates to a metabolite called laudanosine. Why is this drug safe in somebody with renal or liver dysfunction? Because it does not need the kidneys or the liver in order to be metabolized. This drug can, spontaneously be metabolized to its metabolite called laudanosine. Now, I didn't say that the metabolite here is harmless, because laudanosine can actually cause seizures. But this drug is considered safe if you've got hepatic or renal impairment. Mivacurium is a second example of a drug that has a very short duration because it's metabolized rapidly by plasma cholinesterases. Our other category of skeletal muscle relaxants, depolarizing, non-competitive, nicotinic agonist. It's interesting to even call this a category because it only contains one drug, and that is the drug succinylcholine. But it's important to point out that succinylcholine is completely different in its properties from the previous group that we just covered. First of all, it's depolarizing instead of non-depolarizing. It's non-competitive instead of competitive, and it's an agonist instead of being an antagonist. Pretty easy to see why this drug is totally different. Simply put, succinylcholine as a drug has the following structure. If you were to take two molecules of acetylcholine and attach them together, if I attach acetylcholine to acetylcholine, I have just created the drug succinylcholine. Isn't it pretty easy to see why this drug works as an agonist? After all, it is acetylcholine. In fact, I call it acetylcholine times 2. It can stimulate nicotinic receptors, and that's why it causes the membrane to depolarize. Recognize that the non-depolarizing neuromuscular blockers all are simply blocking the alpha subunit. They're never going to activate the skeletal muscle and cause it to contract. But succinylcholine will cause an initial depolarization and muscle fasciculation. So when you give a skeletal muscle relaxant and the muscle contracts before it relaxes, we know that that was succinylcholine. In fact, as we continue on in what's called phase 1 of the action of this drug, depolarization, fasciculation, ultimately leading to a flaccid paralysis. You see, nicotinic receptors are readily desensitized. When you give somebody succinylcholine, it will continue to stimulate those nicotinic receptors until they stop responding. In other words, giving this drug, which is an agonist, eventually will work like an antagonist because you have desensitized the receptor. But that's what makes this drug non-competitive. I can't overcome the actions of an agonist by increasing the levels of acetylcholine because that would be another agonist. So notice the differences between succinylcholine and drugs like atracurium. If I were to use an acetylcholinesterase inhibitor in the presence of succinylcholine, in what's called phase 1, while the drug is still stimulating the skeletal muscle, I'm going to enhance that action. With more acetylcholine, I will more rapidly desensitize the receptor and lead to paralysis. Most often, if you need to have somebody recover from succinylcholine, they're going to recover on their own because of rapid metabolism of this drug by pseudocholinesterase. If not, you could certainly consider ventilatory support, because an acetylcholinesterase inhibitor has very minimal to no effects even if we wait until phase 2 when the receptor is starting to try and recover from its desensitization. I expect a short half-life from this drug. Rapid metabolism by pseudocholinesterase is going to lead to a very short half-life. But recognize, some individuals have an atypical pseudocholinesterase. This is another one of those genetic polymorphisms to be aware of. In fact, if a patient does not recover quickly from succinylcholine, if it takes hours for them to recover, what do you suspect? That's right, that they have an atypical enzyme. They can't metabolize the drug effectively. I want to watch out for the side effect of hyperkalemia. This is especially critical in burn patients, patients who've had severe muscle damage, cell death causing the release of potassium, because succinylcholine, which stimulates nicotinic receptors, when you stimulate those nicotinic receptors, that is an ion channel coupled receptor. Sodium goes into the muscle, but potassium leaks out of the muscle. With persistent stimulation of the receptor, more and more potassium can leak out of the muscle cells, so hyperkalemia is a side effect to watch out for. I also want to be aware of the ability of this drug to cause malignant hyperthermia. We're going to discuss this in more detail on our next slide. In the margin is a note about malignant hyperthermia. This is a life-threatening syndrome where the patient gets muscle rigidity and hyperthermia as key features. They can also get hypertension, acidosis, and hyperkalemia. But once again, focus on the muscle rigidity and hyperthermia. It reminds us of neuroleptic malignant syndrome, and perhaps it even reminds you of serotonin syndrome. So those three types of syndromes have very similar presentations. However, it's easy to distinguish the causative agent because in the test question they're going to give you the history of the patient. Was the patient being treated for depression? Well, perhaps you're leaning towards serotonin syndrome because they were probably on an SSRI. Were they being treated for schizophrenia when they got muscle rigidity and hyperthermia? Then perhaps you're leaning towards neuroleptic malignant syndrome. But if they're being given a drug for intubation, you're thinking succinylcholine, muscle rigidity and hyperthermia in that case says it's malignant hyperthermia. So when I look at what are the causes for malignant hyperthermia, the primary cause is succinylcholine, though some other anesthetics even can contribute to this effect. The most common scenario for malignant hyperthermia is that you have a patient who is already genetically predisposed to this condition. The reason why someone could be genetically predisposed to malignant hyperthermia is because they have mutations in the genes that encode ryanodine receptors in their smooth ER, or perhaps it's a component of the L-type calcium channel found in skeletal muscle. This person has a problem with the regulation of calcium in their muscles, so they are already genetically prone to malignant hyperthermia. If you give this individual succinylcholine, that's when it shows up in the test question. The treatment for malignant hyperthermia is the drug dantrolene. You have to know the treatment. In fact, you really need to understand why dantrolene is effective, not only for malignant hyperthermia, but also for neuroleptic malignant syndrome. Dantrolene is going to decrease contractility of skeletal muscles by blocking calcium release from the SR. When you block calcium release, you stop muscle contraction, and therefore the temperature of this person is going to decrease. Remember, our key features, hyperthermia, muscle rigidity, both of those will be reduced by the actions of dantrolene. We end this chapter by talking about centrally acting skeletal muscle relaxants. There are times when you've got excessive muscle tone or spasm perhaps due to an acute muscle injury. Perhaps it's even CNS dysfunction, like cerebral palsy or MS or stroke. We need a centrally acting skeletal muscle relaxant for these individuals. Commonly, we see benzodiazepines used for this purpose, benzos working through GABA-A, or we could use the drug baclofen, which works through GABA-B. We spent a lot of time focusing on GABA-A. Here's the one drug that we discuss that works at GABA-B. And you know what's nice about that? The GABA-B drug starts with the letter B. So GABA-B can remind you of GABA-baclofen. It's a centrally acting skeletal muscle relaxant. GABA-B, remember, is coupled to potassium channels, whereas GABA-A, chloride channels.